Hello and welcome to this special show on Rajya Sabha Television. I am Vishal Dahiya, and here we take a stock of the fight against COVID-19 pandemic. Exactly what's happening on the ground. Now, of late, there have been reports of reinfection, that is, some COVID-19 patients who have recovered from the first wave of infection have been reinfected with the virus. Now, we'll try and find out what exactly might be the reasons there, what it should convey in terms of our immunity against COVID-19 and also how antibodies work. We're joined by a distinguished panel of guests here. Let me first introduce them to you, beginning with Professor N.K. Ganguly. He is the former Director General of Indian Council of Medical Research, that is ICMR. We're also joined by Dr. Nishant Kumar, consultant and ophthalmologist with the Hinduja Hospital in Mumbai, somebody who has done a study on this aspect with the health workers. And we're also joined by Dr. Sanjay, Professor of Community Medicine at AIIMS, New Delhi. Let me begin with you, Professor Ganguly, and let's first try and put things in perspective for our viewers here, because our knowledge with respect to COVID-19 virus and how it works, that's SARS-CoV-2 virus, is obviously expanding with every passing day. We get to understand and know the virus a bit more. That also brings in focus the aspect of reinfection and how antibodies work. So what's the situation? What's the latest in terms of what we know about this particular virus, the way it infects us or reinfects us?
Actually, Sanjay, the virus infects us through a receptor which is known as ACE2 receptor. But this COVID-2, it has a protease which creates a new area, opens a new area in the spike protein, which also reacts with the membranes, with the clathrin and other adhesive molecules. It enters through two mechanisms within the cell, and it creates tremendous perturbation there. We don't know whether there is a latency or not in this, but they may stay there. But it is seen as a foreign particle, and our body launches an immune response to this. There are two kinds of immune response. One is humoral, which is the antibodies. Antibodies are IgM, IgG, IgA, IgE, IgD, etc. IgM is the first antibody which develops and which shows a recent infection. IgG comes after that. It remains for some time. IgA is one of the antibodies which prevents the virus entry or entry of the antigens into the system, and it can withstand the intestinal proteases, whereas IgE is the allergic antibody. So essentially, we have largely depended for COVID infection from the interpretations of the IgM and IgG antibody, sometimes IgA antibodies. So all our test systems detect IgM and IgG, and some detects IgG alone. The antibodies, as we have been discussing, initially it was shown that if you have an antibody, then you are perhaps protected. That was a false notion. And the immunity passport which Germans and others started really didn't work. Antibody only show that you have been infected in the past. IgM stays for a very short period. So if you are lucky, you can get IgM and can detect that it is a recent infection. But there are neutralizing antibodies. Neutralizing antibodies actually protect, and T-cell immunity, which is cell-mediated immunity, also protects. So neutralizing antibody fall very sharply. It reaches peak and then it falls during natural infection. It falls very, very sharply. And IgG, etc. also fall much sharper than the other influenza and other infections. So that has the worrying point over there, that how are we protected in this? So two major classic reinfections, one in Hong Kong and another in Nevada, were investigated very closely. The Hong Kong one after the second infection, because now we can sequence, we can know that what is the virus. So there are 7 clades of virus with mutations. So the Hong Kong one created very mild infection on a second infection. So we said that nothing to worry. If you had one infection, if you have reinfection, don't worry. It will have a milder version of infection. But Nevada one showed full-blown second infection, full-blown infection. So when they sequenced that, they found that there is a strong mutation over there. And this mutation makes it a new virus. And so it can, even if there are remnant antibodies, it will infect. However, the vaccines are taking a conserved area. Up to now, they can handle mutation. I don't know whether in the future they will be able to handle mutation, because mutations are happening very rapidly. And with the mutations, we can now even predict whether this person will go from outdoor to indoor or to ventilator, or mutations are being used to track also. So at this given moment, this is the state of art.
Okay, we'll come to the vaccine part a bit later, but one more question before I move on to Dr. Nishant here, to you, Professor Ganguly, and that is, now this means that the antibodies which are developed in the body after the first infection, or when the any human being is infected with that particular virus, do have a specific life in terms of the time frame till which they will be present in the body to protect us from further infection. Is there a time limit which has been brought into focus here, perhaps maybe 50 days, 60 days, or is that something which is still under study?
Bodies take time to develop. IgM takes about 7 days to 10 days to develop and then falls sharply. And if it is positive, you can say it's a recent infection. IgG antibodies have 21 days of half-life, and it remains there because there are memory cells in the IgG antibodies. If you again get exposed to the virus, it jumps again and sharply rises. However, that is why the IgG antibodies have been largely used for serosurveillance, that you had an experience with virus, and it is a signature which shows that you have had experience with virus. Problem here is this, that some of our other, for this particular infection, we are seeing that even IgG antibodies are dropping. And the signature of virus really doesn't help, because we were not doing diagnostics properly. RT-PCR, if you do cycle-wise, if the virus load is very high, it is caught in a higher cycles, and if the virus load is very low, they are caught in a lower number of cycles. So the lower number of cycles and higher number of cycles have not been used in our country. Like if you have a very small viral load, you might not transmit it. So you might have to do twice the test to really see that whether you will be transmitter and have your virus load has increased. So that is how we learn about it. But antibodies at this time, the IgG antibodies are the signature which virus leaves in the form of antibodies, is used essentially for serosurveillance, but not for immunity. Immunity is neutralizing antibodies.
Okay. That explains a little bit, and makes it much more clearer out here. But Dr. Nishant, I'd like to, seek your views on or further clarify about the reinfection part, and also how does your study, correlate with this particular aspect of reinfection and the lifeline of or the lifetime of the antibodies within human being?
So thank you for having me, number one. Number two, we were doing a large study, which is through my charitable foundation, where we looked at 800 doctors, nurses, ancillary workers, and it was part of a sero survey. I think it was one of the earliest sero surveys that was done in Mumbai, which was one of the biggest hotspots that we had in the country. And as you know, a lot of doctors, unfortunately, have lost their lives, a lot of nurses have lost their lives. So this was done in June, and you've got to take this kind of, that every month the sero surveillance data is going to keep changing. But what we found is that, that 1 in 10, more than 1 in 10, 11% of people had developed antibodies in the healthcare workers, which was less than what we're now seeing in kind of on the serosurveillance data otherwise, which was which was good for us because, we thought the numbers would be much higher. That means that the PPE kit protocols, the protection protocols had helped to some extent. What we also noticed was that the ancillary workers, these are your cleaners, porters, the people who are not the doctors and nurses, but are a very integral part of hospitals, they were far more infected than kind of the doctors and nurses. So 20% versus 7%. Which basically tells us that, that these are the people who are, the ayabais, the mamas, the maushis. They are not maybe being as educated and the protection protocols are not as severely followed for them. But the thing is that they're the ones who are cleaning you, changing you. So if they're infected and they could spread the infections, they become super spreaders. So that was one more lesson we learned, that, that we need to spend more effort educating these people who are by and large pretty ignored in the hierarchy of medical systems. Mm-hmm. And the third thing that we found was that this designation of COVID versus non-COVID hospitals is probably theoretical, where I think everyone agrees that we're seeing just as many COVID patients in non-COVID hospitals now before they get diagnosed. So the seroprevalence of people who are working in non-COVID hospitals is actually higher. Mm-hmm. So the doctors may be having a false sense of security that I'm in a non-COVID hospital, therefore maybe letting down their guard as compared to somebody who's working in a COVID hospital. So we found that, that in non-COVID hospitals, the seroprevalence rate was much higher among doctors, nurses, and ancillary workers as compared to COVID hospitals. Mm-hmm. So that was kind of baseline data. The more significant or exciting data that came out was that we found that there was a bunch of people, about 65 people who were already PCR positive and had resumed duties. That means that they've had an infection and they've come back to work. We looked at them to see how many of them yet had antibodies. And what was surprising is that after 50 days or after 7 weeks, none of them had any antibodies. Okay. So if you looked at kind of, obviously for the first 2 weeks, you're quarantined, so we didn't have anyone in that group. Between 2 to 3 weeks, it's on an ascendancy, as Dr. Ganguly very nicely pointed out. So about 40 to 50% of them had it. Between 3 to 4 weeks, 90% of people had developed antibodies. But then you see a very sharp drop. You see that, between weeks 4 to 7, it comes down to 40%, then comes down to 20%. And after week 7, we had 28 people in that group, which is quite a big number if you look at the studies published so far. But none of them had antibodies, which basically means there's a very rapid decay of antibodies happening. And the antibodies are dropping down to non-detectable levels. Now, you've got to understand that we use the Roche kit, which is a commercially available kit. This is not a research kit. This is something that you can go and get in your kind of normal pharmacy or normal laboratory. But they look at all antibodies, IgG, IgM, and IgG, total antibody. But we found that none of them had antibodies. Now, the significance of that, I think, is twofold. Number one, Dr. Sanjay will be able to help us more. But when you're looking at vaccines, how do you measure immunity and what is it generating? You normally measure antibodies. There's research labs are able to look at T-cell immunity and look at how effective it is. But for normal kind of labs at the moment, your antibodies is the only thing you have. So the antibodies drop very sharply. Okay. And that's why we're now seeing that this reinfection rate, whether that has something to do with it or not, we don't really completely understand. What is all the mutations which are causing it, we don't completely understand. But we know one thing for a fact, that all those people who are going out saying, I've had COVID, so I don't need to worry because I've got antibodies. Well, after 50 days, you don't have those antibodies. So for what it is worth, you thought that you were kind of protected. And ICMR called their test also the COVID kavach. Unfortunately, it's a temporary kavach. It's not the current kavach which would give you immortality. It's a kavach which after 50 days just disappears. So I think we need to just be aware about that. So those are the significant findings.
Okay. So clearly, makes things much more clearer here that the lifespan of antibodies in a human being is somewhere around 7 weeks, as Dr. Nishant is saying, and the reinfection cases which are now coming to light does give credence to these particular findings. Let me bring in Dr. Sanjay here. Dr. Sanjay, your views on this concept of reinfection and how antibodies work, and the most important aspect here. How would it, change our strategy or our perspective with respect to the public health?
This SARS-CoV, we all know this SARS coronavirus 2 is only 8 to 9 month old virus. So we have very limited knowledge about, this is the fact, about this virus, about the overall the duration of protection, etc., all this. But whatever knowledge we have globally and also from India, I will discuss one by one. Mm-hmm. Also, WHO has officially said that this virus, protection from this virus after infection is not a guarantee for also Dr. Ganguly mentioned for immunity passport. Definitely, you can't provide a guarantee. So that's why they denied. No, don't provide a guarantee that you are completely. But whatever evidence we have, Like globally, more than 2.5 crore people have already been infected with this virus. More than 8.5 lakh have died already. Right? There are very few cases of reinfection. Like if you recall, during May month, a few cases from South Korea. They reported around 80 to 90 cases. Then few from the China also reported few cases. But finally, we found that they were not the live virus. They were the debris of this is RNA virus, and they detected that. So through RT-PCR, you can detect. Otherwise, see this huge number, 2.5, more than 25 million people have already this infection, and majority have recovered. And see that second wave, infection will occur. Then there will be multiple waves. The second waves occurred where you forcibly contain this virus. So through lockdown or various other non-pharmaceutical interventions, not through the natural infection, like Dharavi, we control the natural infection rate is more than 50%. Newark, right? So we are not seeing any second wave. Even Mumbai is very closer to this herd immunity. Almost 40% people are already infected last week. So based on all this, I can say that this virus is only 7 to 8 months. So up to this period, that means 6 to 7 months, we are protected. Our majority of us are protected. But see, this like IgG level, there are various way of immunity. It's a very complex mechanism. Immunity is very complex mechanism, body's mechanism. So there are humoral immunity and cellular immunity. This IgG is a humoral immunity, and we are detecting this only. So even after 7 weeks or 8 weeks or 10 weeks, suppose if its level is declining, we can't say that we are not protected, right? Our cellular immunity may playing a role. There are various other diseases where cellular immunity is only playing role, not the humoral immunity. So whatever evidence we have, I can say that for this period of time, tomorrow we may change our stand. That no, there is no guarantee that after, but at least for 6-7 months we are protected. Yeah.
Okay. So what you're saying here is that it's neither a black or not a white sort of black and white sort of situation. We need to understand this much further. Perhaps more studies might throw some more light. But that's the lifespan of the antibodies. But even after that particular lifespan, the immunity might still kick in. But then this does not take away the caution here, and that caution is that we cannot consider it as granted, that we are immune to it if we are infected once. That's one part. Second part, which Professor Ganguly started, spoke about in his initial response. I'd like to come to that because that's really, really important. How these new developments, that is, reinfection cases, are getting to know in more detail about how immunity or antibodies work. How will this affect the development of a vaccine, the COVID vaccine, which is being worked upon? There are several vaccine candidates which are being worked upon, because mutation is a very, very important angle here. Professor Ganguly, let's begin with you.
Yes, Vishal. Actually, what has happened that now there are about 7 to 8 clades which are circulating around the globe. And some of these clades have distinct signature, European clade or Chinese clade, and now we have Indian clades also. And we know that some of them can infect very mildly, the others can infect, cause a very severe infection. But these are separating and mutating. And some of the small mutations which we had been ignoring are also coming to be very, very important. So when we are that is why whether it is influenza virus and whether it is a COVID virus, as Sanjay ji was saying, normally it is 6 to 7 months the antibodies protect, and every year you have to vaccinate, and sometimes you have to change the strain also, as it is found in influenza virus, and WHO provides this advice based on the surveillance. I think same will be happening for COVID also, that it might be an yearly vaccination. But in the vaccine design, what people are doing, because if it mutates so much, it will become very difficult to really protect. So in fact, there is a receptor binding domain in the spike 1 and spike 2 proteins. This particular area has a conserved area, which is common to all the COVID-19 viruses and will remain common. So people, with the vaccine design, they choose this area so that the protection, even if some mutation occurs, protection will still happen. So vaccine, when it is given, will not be like antibodies. These will be protecting. The problem comes that they need to produce good neutralizing antibodies. Okay. So not all the vaccines are producing that height. The neutralizing antibody assays are very difficult. They are done in two ways. One in the live virus neutralizing antibody, using live viruses. You need BSL-3 facility for that. The other one are the host cell assays. And these complex assays then give the height of neutralizing antibodies. So neutralizing antibodies fall sharply. So even the vaccine will not be an answer, that it will not be there. So at least in the vaccines, we will know these only when the phase 3 is completed. We will know more about the safety. We will know more about the protection, efficacy. If we give a vaccine without fully knowing its efficacy and safety profile, it will be disaster of a magnifying proportion, because very large number of people do not believe in vaccine. In India, in other countries, there is an anti-vaccine lobby which has been fighting against measles vaccine and other vaccines, even going to Supreme Court with petitions. So if the vaccine doesn't work, then there will be an explosion in the anti-vaccine sentiment, and it will be very difficult to really overcome that. So what I will say, that we should not race towards a vaccine. The public health measures, which Sanjay Rai knows much better, the wearing of the masks, the social distancing, washing of the hands and sanitation, and behavioral changes, so that people do not become cocksure. Like if they take vaccine and they become cocksure, I need not do social distancing, I should not wear mask and others, it will be another disaster. So here the behavioral people and public health people like Dr. Sanjay and others need to work with the communities to create a confidence in them, and know where we should break that confidence by creating a prescription that just give after it is an epidemic of a pandemic of a big proportion. After phase 2, just give the vaccines as the Russians have done. I will not do that for our country if I have any advice giving capacity.
Okay. We'll come to Dr. Sanjay on those aspects which you pointed out, Professor Ganguly, and we'll definitely take his concluding comment there. But before that, Dr. Nishant, your views on this entire issue here. We getting to know a lot more at every stage, at every bend, every turn about how this virus works. Does that, change the goalpost for our researchers and scientists in achieving the ultimate here, and that is, developing a particular vaccine which is effective against this particular virus?
I think, one of the very learned people said that the more research that's done on this vaccine, the less I know about it, So I think we were very sure about things in January, February, March, and then the research started coming out and we said, oh God, this is not the way it works. So I think the more research I've done, I think we have to be humble and say the less I understand it, that means the more hard I have to work to be able to understand it, rather than sticking to my dogma and saying, no, this is what I said first, so I'm going to stick to it. So I think luckily we've been very fluid about it. I think the bottom line for your listeners and for people like me, I'm an ophthalmologist, I'm not as smart as Ganguly Saab or Sanjay Saab, is that, that the vaccine is not going to be as quick, as simple, and as simple a solution as people are making out to be. I think the road to the vaccine is yet far. I think if a vaccine comes, you're going to need multiple doses. The vaccine will mutate and you're going to need to grow with it. So I think when they say you're going to have to live with this vaccine for a bit longer, I think the virus is showing up a lot of different things that people believed earlier would work. We were hoping that antibodies would last forever and, they'd be a sure shot. there's really no great way to be able to measure T-cell immunity. So if I, as a person on the street, wants to know, do I have T-cell immunity? Am I slightly protected? I can't go and do that. I don't have a laboratory test readily available to me. So what we have at the moment is some good science to tell you that, listen, you need to protect yourself. Bottom line, the vaccine is going to be a while away. I don't think we should be in a rush to launch a vaccine. I think there have been lots of vaccines that have ended up in disaster. A good one was the dengue vaccine. Sanjay Saab will be able to tell you. After the vaccine, more people died of dengue than before the vaccine. So, so vaccines are a very complex issue. It's not as simple as saying, oh, I gave it and then I'm protected for life. You see so many side effects. I, as an ophthalmologist, see people developing eye problems, blindness, myocarditis, post-vaccine, which are routinely available. So we yet have to understand what this vaccine is going to do. I think there's a lot of work ahead. I think the only thing we can be honest and say is that we understand this virus very limited. Globally, there's a lot of effort going on. Until we don't get the answers that we understand, as Ganguly Saab said, social distancing, wearing a mask, not congregating, and not getting cocky about it.
Okay. So as you said, if I sum it up correctly, being humble about our knowledge about the virus and not lowering our guard against the virus at the same time as well. Would you agree, Dr. Sanjay Dahiya? Concluding comments from you.
Yeah, absolutely agree. See, the best way to prevent is to avoid being exposed to this virus. We don't have any vaccine. We don't have any effective treatment. So this is the best way. And how can we avoid? Both Dr. Ganguly and Dr. Nishant, they have nicely summarized this, like wearing masks, etc., all these non-pharmaceutical interventions. So I fully agree with them.
Okay. Well, thank you so much, Professor Ganguly, Dr. Nishant, and Dr. Sanjay for being with us and sharing your views with us and our viewers on this aspect of reinfection and how the antibodies work vis-a-vis COVID-19. How does our immune system work against this particular virus? As one of our panelists pointed out, the crux is that we need to be humble about our knowledge of this particular virus and the way it works, and at the same time, cannot lower our guard. We will continue to go ahead and take preventive measures, the most important amongst them being wearing a face mask when we step out of your house. So please do not forget to wear that face mask when you step out of your house or go for any other work. Keep watching Rajya Sabha Television. We'll come back again. Thank you.